Okay, well, as you all know, we had the government shutdown for 2 weeks, but Traco, we just lost one lecture out of all that period of time. So I'll see if we can reschedule that lecture. And then also I started sending out notices about the core facilities. If any of you sign up for the cores or the tumor boards, we're starting up those visits now. And on Friday, actually, we have a visit to the small molecule core. So I sent people emails about that. And if any of you want to participate, just send me an email and I can send you the instructions. So we're back on schedule. Today we have Pete Choyke talking first. So he got his medical degree at Jefferson Medical College. Then he did a residency at Yale New Haven Hospital. Subsequently joined the faculty at Georgetown University, and we recruited him here to NCI at 2004. His title, Imaging of Cancer. Subtitle, What Actually Happens in the Radiology Department. Pete.
Thank you, Terry. And good afternoon, everyone. So I'm a radiologist in the NCI, and I thought I would take this lecture rather than to try to cover all of imaging of cancer, to try to describe some of the imaging tools that we use in a radiology department so that you have a better understanding of what their capabilities are and what their limitations are. As you can see on the top of the slide, many of these devices externally look very similar to each other. They all have a gantry and a table, and the patient lies on horizontally, and then they're scanned. But what comes out of each one of these machines is radically different. And so, why do we bother with imaging of cancer? That it perhaps is a little self-evident, but imaging is really key for a variety of different applications in cancer. For screening, there are a number of techniques that can be screened, like lung cancer and breast cancer can be screened with imaging. Detection, if a person has very high risk or their serum biomarkers suggest that they might have a tumor, these scans can be used to detect the lesion. Staging it, has it spread locally or is it metastasized more distantly? Once they're diagnosed and staged, we need to monitor their treatment. Are they getting better or are they worse? Assuming that they get better, we monitor patients for recurrence, that is, has it come back, and ultimately prognosis. The patient wants to know what will happen to me. And the scan can often tell them a great deal about the future. So what I'm going to talk about today are 5 imaging techniques, and these are the ones that I consider the key imaging techniques in a radiology department: CT, MRI, ultrasound, SPECT, and positron emission tomography, or PET. So my quiz to you is, can you name which scanner is which? And I think most of you can recognize off to the right that there's a device that looks pretty different than the others, and that's the ultrasound device. But otherwise, it might be difficult for you to distinguish between these different technologies. But here's what the answers are. And so we'll go into a little depth. Let's start with CT, computed tomography, which is the workhorse technique for the radiology department. In the radiology department of NIH, over 100 of these patients are done each day during an average clinic. And they're used basically across the board. So it gives unprecedented resolution. So the advantages of it are that it's widely available. There's no distinct patient prep for it. The patient shouldn't eat immediately before the scan, but other than that, there's very little preparation. It's an extremely rapid technique. here I have 30 to 40 seconds from the neck to pelvis. Actually, on our latest scanners, that time has been reduced to 15 seconds from here down to the pelvis. It's a single breath hold, and literally thousands of images are generated in that time period. And they're extremely high resolution. And after all is said and done, with the modern technology, it's relatively inexpensive to do that. But there are some drawbacks. Every time you use CT, there's a certain amount of radiation that's absorbed by the patient. It often requires the use of intravenous contrast media, which we'll talk about. And at the end of the day, what it provides you with is anatomic information, but not anything about the physiology of what's going on in a tumor. So let's start with the basics. This is an X-ray technique. And all X-rays, whether it's just a plain film X-ray or it's part of CT, rely on something called a cathode ray tube. During a cathode, what a cathode ray tube is a coil of wires that through which an electric current is passed, and very high energy electrons are released from that coil in a vacuum, and through magnetic force fields, basically, they're accelerated towards this anode, which, as you can see, is angled so that the X-rays that are released from this anode are directed in a certain direction. And so this is the basis for all X-ray production, the cathode ray tube. Now, what goes on in a CT is you have just such a tube mounted in the gantry, and it revolves around the patient. And instead of plain film or film, as we might do with a conventional radiograph, we have a series of solid-state detectors that detect the amount of energy that's coming through the patient and making its way to the detectors. And then the patient lies on the table and travels through that gantry to create the 3D images. So that conceptually is okay. You have this tube, it sends X-rays through, it rotates around the patient, but how do you generate the actual image? And I think this illustration is probably the best. On the left side, you have a very simple sample of 4 little tubes, 1, 2, 3, 4. You have an X-ray source that moves around, and it creates projections in different planes depending on where the X-ray tube is projecting. So if it's going straight through, it makes 2 bumps. If it's coming at an angle, it will make 3 bumps, and so forth. And then if you back project all of those projections, back project them into virtual space, you can see that you could reconstruct those 4 different tubes. And that's the theory of back projection reconstruction. And so each one of those can form a slice. You can stack those slices and do some image processing that will enable them to become a 3D volume. So you can look at them, image in any plane that you choose. Now, back projection is good, but it's not quite as accurate as doing what we do now, which is a Fourier transform, which I don't have time to go into, but suffice it to say that it's a mathematical way of dealing with all these curves to reconstruct the image in a way that gives you a cross-section of the body. So if you break away the anatomy of a CT scanner, you have this very high speed X-ray source or cathode ray tube that's going to revolve around the patient at very high speeds, many times a second actually, a detector array that is present on the opposite side of the X-ray source, and the production of a fan beam of X-rays that enable the patient to be scanned. So you may hear about what we call spiral CT or helical CT, and you may be curious about what that is. Well, as I mentioned, the X-ray source shows this beam, creates this beam that goes through the patient, and it's picked up on these detectors. At the same time, the patient is moving through this fan beam. And so, in essence, it describes a helix or spiral around the patient as the patient moves through this fan beam. So that's where the term spiral CT comes from. And because you can stack these slices very closely and actually get 1 millimeter slices through the body, what it enables you to do is look at the images in any plane. This is the native plane, the so-called axial plane. But you can stack all these axials together to create a coronal plane, or look at them sideways to create a sagittal plane, all with the same data set, no extra radiation. So one data set allows you to look at the patient in multiple planes, just like this. So that's called volume CT imaging. Now, one of the things about the body is that it attenuates the X-ray beam to different degree depending on what part of the body you're going through. So for instance, if you're going through the lungs, which are largely just air, there's relatively little attenuation of the X-ray beam. And as a result, we get a sort of a black image corresponding to the lungs down here. On the other hand, as you go through the pelvis, it's almost all bone. And so the X-rays have relatively more trouble getting through bony tissue. And so you can see that the bone is read out as a white color, if you will, corresponding to high density. And the reason this is important is that radiation exposure of patients has become a very important issue in CT. It turns out that among all the sources of radiation in the environment that ordinary citizens would be exposed to, CT is probably the #1 source of radiation because it's done so frequently, and it has a fairly significant source of radiation. Other sources are flying in an airplane at 30,000 feet, being exposed to radioactivity of some sort, but that's very unusual. So CT actually is a major source. And before a landmark paper where people went back and looked at individual patients at Yale and looked at how much radiation they were receiving over the course of their therapy. And then they asked the physicians, how much radiation do you think your patient is getting? And they were completely mismatched to those two numbers. So it started to raise awareness. And then there was a really bad event that happened in Los Angeles where a machine got stuck in the on position and a young child got a radiation burn on their head from a CT scan. And that was it. And then the regulatory agencies moved in and said, we've got to do something about this. So there's been a steady development of reducing the amount of radiation from CT. And really very salutary results. That this is from just one study at Mass General, where the benchmark or the before they put in all the techniques to lower the amount of radiation, they were able to basically lower the radiation by a factor of 2. And recently, on our scanners, we've been able to reduce it almost by a factor of 10 in pediatric patients. So it just shows you, once you're aware of a problem, you can solve technical issues. And so that's something that's happening a lot. And another side issue on CT is that we often use iodinated contrast media. That enables us to convert this image, which is obtained without intravenous contrast, into this image, which has much more nuances to it. You can actually see vessels within the liver. You can see within the kidney, the collecting system, a cyst here. You can see the inferior vena cava and the aorta. And so there's much more information that can be derived from a contrast-enhanced image than from a non-contrast enhanced image. So this was a big development. But there are some concerns about whether iodinated contrast media will hurt patients' kidneys. So that's one of the things that we always check for before we administer contrast. So when you see an image of a CT scanner, you'll often see this device perched right next to the CT, which is an automated injector. So it's a motorized injector because we have to get a large volume of contrast into the patient very quickly in order to get good contrast. So we need a motor to deliver it. Just delivering it by hand is not adequate. So it looks like this. It's got two syringes. One syringe is for the contrast, and the other is for saline that chases the rest of the contrast into the patient. So it's a two-syringe device. And that's just the way it looks. And this is what a bottle of typical non-ionic contrast media, IsoVue 300, looks like. So there are several different iodinated contrast media on the market. They typically have a configuration like this where you load on iodine onto, say, a benzene ring, and the iodine blocks the X-rays. So it increases the attenuation of the X-ray beam, and so you can see where there is contrast media in high concentration. But it takes quite a bit of iodine to block X-rays. So the typical dose, and this is a routine dose of contrast that we give, is between 30 and 45 grams of iodine for a contrast-enhanced scan. That's routine. So it tells you something about CT. So some people find it surprising that these two images, the one on the left and the one on the right, are exactly the same image. We didn't take two images to get these two different things. All we did was manipulate the image so that one looked like this and the other looked like that. And the secret to this is the use of grayscale windowing. So this is a digital image, and it ranges in density from -1,000 to +1,000, +1,000 being bone, -1,000 being air, and 0 being water, right in the middle. And so you can adjust the so-called level and window to bring out structures like the heart, in this case, or by changing and widening the window and lowering the level, you can bring out lung structure. And so it becomes very flexible. You can focus on mediastinal structures, on pulmonary structures, on bony structures, and you can actually optimize that to what you're looking for. So that's CT. Let's talk a little bit about MRI, magnetic resonance imaging. And this is an example of an MRI of the prostate with a tumor, and you can see that same tumor on a histopathologic specimen. So you get very good delineation of a prostate cancer on MRI. Now, MRI has several advantages. First of all, no radiation. So after everything we've talked about, that should be of interest to you. Secondly, it's inherently multiplanar. So you can scan not just axially, but you can scan sagittally, off axis, any direction that you choose. There are multiple different contrast types. Note in CT, you only have one choice, CT attenuation, X-ray attenuation. In MRI, you can choose T1 weighting or T2 weighting, diffusion weighting, contrast enhanced or non-contrast enhanced, spectroscopic imaging, and that just begins the list. Those are the most common things we do. So it's an extremely flexible technique. What are its disadvantages? It's slower than CT. It is a more expensive device. It has no ability to depict calcifications, which can be important in some issues. And there are also some safety issues related to the use of a high magnetic field in a medical environment. Particularly, some metallic objects can become projectiles. So there's a huge safety issue around MRI. And people are very well trained, if they work in the MRI department, to avoid bringing into the environment anything that might be a projectile. It's also, there are a number of devices that are incompatible with MRI, such as pacemakers and cochlear implants. So in the next few minutes, I'm going to whirl through what essentially accounts for at least 3 Nobel Prizes in the last 60 years. So if you don't get it all on the first time, it's okay. But basically, Protons, that is hydrogen atoms, are like little magnetic dipoles in space. So as we sit here, there are hydrogen protons, and they're all randomly distributed. They may be weakly aligned with the Earth's magnetic field, but the Earth's magnetic field is just too weak to really align them in any degree. But if you apply a very strong magnetic field, something happens. They all jump to attention, either aligned with the magnetic field or aligned 180 degrees against the magnetic field. Now, another thing they do, besides aligning, is they precess around the direction of the magnetic field. Very much the way the Earth rotates around its magnetic axis, these little protons also precess around the magnetic field that's applied. And they do so, they revolve at a very characteristic frequency called the Larmor frequency, or the resonant frequency. That's important because if you apply energy right at that same frequency, you can get these little protons to do things, to do little tricks like get deflected from their alignment with the magnetic field. They get deflected. And as you turn off the radio frequency, they start to relax back to their native state, the state that they're comfortable within, that is aligned with the magnetic field. And when they do that, they release a small amount of energy in the form of radio frequency that you can detect with a radio receiver and generate an MRI image. So that's just to summarize what I've just said. You have all these spins, hydrogen nuclei that are spinning around, either aligned with or against the magnetic field. You come in with an RF pulse. You deflect them from their normal alignment with the magnetic field down to another direction. And when you release or turn off this exciting RF pulse, you get a release of energy in the form of signal here or here, depending on what array or how you play out these various radio frequency pulses. So that's the signal that generates an MRI. And so you can detect these magnetic, these little radio frequency signals and do the same kind of trick. Basically rotate, instead of an X-ray tube, you rotate this magnetic gradient around the patient, and you get different profiles through this 4-point source as you rotate this gradient around the patient. And then using all of these projections, you can compile an image or back project an image that we're familiar with. So the MR device, as I mentioned, is a little more expensive than a CT device, which just has a basic CT tube, an X-ray tube, and a bunch of detectors. Here's the cross-section of an MRI. First of all, you have the space where the patient sits in the bore of the magnet. And then around that, you have various coils, gradient coils and radio frequency coils that deliver the energy. But how do you generate that strong magnetic field? And we're talking 3,000 times the Earth's magnetic field, very, very strong. Well, it requires a superconducting environment, that is, a wire that you charge up with a lot of electricity that wraps around this whole thing. And then to keep it going, you keep it at liquid helium temperatures. So once the electrons are going around there, they're just going to keep on going around. There's no resistance in the wire. It's superconducting. So you generate these huge, high magnetic fields in the center. One important aspect of this is the so-called cold head, where you can deliver liquid helium into the device, keep it refrigerated. But it's also very important that you be able to vent in the event that the magnet heats up for some reason. There's a tremendous amount of gas that will form from this liquid helium converting into gaseous helium, and it'll definitely fill up the room, pushing out all the oxygen from the room, all the regular air from the room, and who's ever in that room at that point will suffocate. So in order to avoid that, you have a vent that takes those cryogen gases away very rapidly. So at the top of every MRI, you'll see one of these vents. So if you ever want to figure out what device you're looking at, look at the top. If there's something coming out the top, going up somewhere, that's a vent. That's an MRI device. Don't go in the room unless you're completely demagnetized. So this is what it looks like from the outside. Here's the quench pipe, the vent that I just talked about at the top of the unit. An injector, just like on CT, we have a 2-syringe injector. But there's another very important piece of safety on an MRI device, and that's this ear protection. Not only do we give patients earplugs, but we also give them these ear-protecting headsets, because there's a huge amount of noise generated inside one of these magnets caused by the gradients shaking. And as a consequence, we need to protect the patient from the high sound. Now, this is a very strong magnetic field, and anything that is potentially magnetic can get sucked into the magnet. And although this is sort of a comedy, for people in the business, this is a very, very serious issue. I've actually seen an MR tech tackle someone before they got into a MR scanner because they had something on them, a pair of scissors that they knew could become a lethal projectile. And this tech took them down. They're trained to do it. So it's like the Secret Service. So MRI scanners are very powerful, thousands of times the Earth's magnetic field. And one of these objects, like keys or scissors or any number of things, can achieve speeds of 60 miles an hour from stationary as they get pulled into the magnet. And it's a very significant potential source of injury to people if we're not careful about it. So here's some horror stories. That's a floor buffer that people didn't realize. One of the things is people think that when you turn the lights out in the scanner, the magnetic field is off. No, the magnetic field is always on. And so even in the middle of the night when they come in to buff the floor, you can have a total disaster. Good news is nobody in the magnet. There's a cabinet that got sucked in. It's a metal, cabinet. Not a good idea. And perhaps, one of the saddest things is when an oxygen tank gets brought into the room to ostensibly help a patient, it essentially becomes an airborne torpedo that can kill a patient if they happen to be in the scanner at the same time. So take this stuff very, very seriously. Now, just like on CT, MR contrast also exists, and it's very, very helpful in pretty much the same way. Instead of iodine, though, we use an element called gadolinium. And in fact, we're not really looking at the concentration of gadolinium so much as the effect that gadolinium has on those spins and how fast they relax back to the native magnetic field. So there are a number of different agents that are commercially available, and they all have gadolinium in them. Some have a kind of caged chemistry that prevents the gadolinium from escaping, and others have a more linear relationship with the gadolinium. And I just want to point out that there is something called thermodynamic stability, and that is how tightly the gadolinium is held to the binding molecule and how easily the gadolinium is released. So gadolinium is not a harmless substance as an ion. Gadolinium is a heavy metal, and it accumulates in the liver, it can accumulate in the bone marrow, and it can cause toxicity. So it's very important to tightly bind the gadolinium to a structure that will enable it to be rapidly excreted once its job is done. And so some of these agents have very high thermodynamic stability. They hang on to the gadolinium pretty much through a nuclear war, and others are not so good. And so that has become an issue because some of these agents will allow gadolinium to be released, especially in patients with renal failure And patients can go on to develop this very peculiar but devastating illness called nephrogenic systemic sclerosis, in which they get a stiffening of their joints and soft tissues. So it's very important that gadolinium not be administered to patients who have renal failure. So this whole entity of NSF was first discovered in Denmark in 2006. A number of other centers subsequently reported seeing it in their patients. And approximately 200 cases have been reported overall, mostly with Omniscan and Optimark, which are those two agents that have relatively lower thermodynamic stability. But since our awareness has been raised about this, since in 2013, almost no cases have been reported of this because we can successfully avoid it. And this is what it looks like on an MRI. There's a lot of swelling and fibrotic tissue in the soft tissues. So gadolinium is highly toxic. Most patients with normal renal function excrete the gadolinium compounds very easily, but patients with abnormal renal function can take many weeks to excrete the gadolinium, and the dissociation of the gadolinium from the chelate can lead to deposition in soft tissues and fibrosis. So let's move on to ultrasound, which is a very useful technique that we employ in the radiology department. So many of you have had interactions with ultrasound. It's really a very fun modality. It's no radiation. It's real time. So you put the scanner down on the patient, you get images right away, no processing. It's very relatively inexpensive. It's quick, little preparation, no injection is needed. But alas, it has some disadvantages too. First of all, it requires a great deal of skill to properly perform an ultrasound. You can't just put it in the hands of anybody and expect to see good images. One of the other things is it's very much like a flashlight in the body, as opposed to turning the lights on in a room, which would be a CT scanner or an MRI, where you could see everywhere in this room. With an ultrasound, what you see is all there is. So if you point the scan in a certain direction, that's what you'll see. If you fail to point it in another direction, you won't see it. So that speaks to the operator dependence of a technique like ultrasound. It's also very difficult to quantify ultrasound, and certain organs just don't permit the use of ultrasound. For instance, the lungs, because they contain air, reflect the sound waves right away, and no image. Brain, well, there's skull. You can't get ultrasound waves through the skull. The bone, same reason. So there are limitations to what you can use ultrasound for. But it is a great technique, and we love having it. So basically, it's a sonar. You send out a sound wave from the transducer over here. It propagates through the tissue. It hits an object, which then reflects it back to the receiver. And so you send out a pulse and listen. And depending on how long it takes the sound to get back, you can then, by the speed of sound, know where that reflector is coming from. And there are all kinds of things that can happen. So you can have something in the tissue that attenuates the sound, so nothing comes back. It absorbs, it reflects, like we just said. It scatters. The sound goes in all different directions, depending on the structure. It can refract, depending on the speed of sound, or diffract, just like optics. And so it becomes a very useful technique. I hope you can appreciate on this ultrasound with liver metastases, these very subtle little areas of increased echogenicity. They're just very subtly different than the normal liver parenchyma, but you can really see a lot of them. And that's strictly because the speed of sound through a metastasis is slightly different than the speed of sound in normal liver. And the machine can pick up that slight difference as an increased area of echogenicity. And that's how the ultrasound works. So the key to the ultrasound is a probe that is usually handheld. It's a piezoelectric crystal through which electricity is passed, and that vibrates at a very, very high frequency in megahertz and sends out sound waves into the tissue. Often you need to couple the transducer to the skin using a gel because if you don't have the gel, there's an air film layer that'll just reflect the sound right back. So you need an acoustic coupling gel to make it work. And these probes come in all shapes and sizes. For little small organs, like the thyroid, you pick a little small probe. For the abdomen, you pick a big probe. There are intercavitary probes like transrectal or transvaginal probes for specialty use. Now, one of the things that's happening in ultrasound is this is the traditional ultrasound device that wheels around and is great. But over the past 10 years, people have been developing smaller and smaller ultrasound devices to the point where they're practically the same as a cell phone. And in fact, there's an iPhone transducer that's available that converts your iPhone into a portable ultrasound device. And that raises the issue about whether all physicians eventually will be carrying a pocket ultrasound as part of, their general practice. The other thing, because it's real time, ultrasound is really good for guiding biopsies. It's fine to be able to identify a lesion in a patient, but you need to obtain tissue in order to determine what that is. And ultrasound is great because it's real time, you can watch the needle go directly into the target and make sure that you're sampling the right thing. Now, ultrasound, I said no injections, but there are some contrast agents available for ultrasound. They're not in wide use, and they're called microbubbles. And basically, they're fairly large by most standards, fairly large, so micron-sized bubbles that contain a gas, perfluorocarbons, that are highly reflective. And so because of their size, they're constrained to be within the vessel, as you can see in this diagram. And when the sound wave comes in, they reflect first, but then also the sound wave can actually burst the bubble. And so it's very nice because you can kill all the signal and then let it refresh in. So you can measure how fast it takes to opacify, say, a lesion. And that gives you some index of the perfusion for the lesion. So here's an example on the bottom of a hepatic metastasis, and then microbubbles are administered, and you can see them accumulating in the vessels inside this metastasis. So it's a good way of looking at things. So let's move on to the fourth of the 5 techniques that I want to talk about. We're making progress. And this is called single photon emission computed tomography, short SPECT. So we break it down into the 2 components, single photon emission and computed tomography. So computed tomography, you guys are already experts in. We don't really need to talk too much about that. That's back projection, no big deal. But the source of the energy for this imaging, unlike what I've described, is radioactivity. Radioactive decay of a isotope that releases a gamma ray. So radioactivity produces one of 3 kinds of energy. When the nucleus of an atom starts to break down, it can release alpha rays or alpha particles, which are basically helium nuclei. It can release beta rays or electrons, or, as we'll talk about in a second, positrons, which are positively charged electrons, antimatter, or gamma rays. And so what we're going to talk about here is gamma rays, fairly high energy, released from particular isotopes. Now, SPECT has some advantages and disadvantages. It's a relatively inexpensive technique. It's been around for a long time, and there's broad experience with it. Of course, now we're back to radioactivity by necessity because it involves a radioactive substance, a tracer element. It's going to involve some radiation exposure. We need to prepare that imaging agent for the patient. because it involves a radioactive substance, and especially since 9/11, there's an intense regulatory process, regulatory safety process, and the scanning is relatively slow, especially in comparison to, say, CT. So let's just take an example of one SPECT imaging agent. How does it work? And probably the most common is the bone scan. So in order to do this, you take a radioactive isotope, in this case technetium-99, and chemically bind it to methyl diphosphonate, which will bind calcium apatite in the bones. And so if you have a patient who's at risk for bone metastases, this technique will localize in areas of metastases. And you can see this image. It looks kind of fuzzy, and we'll get into that in a second. But you can see all these little lesions, and that shows you that this is a biologically active lesion in this patient. So it not only tells you where it is, but it says this is an ongoing active process that can take technetium methyl diphosphonate and incorporate into a lesion. Now, you don't have all day. Well, you do have maybe all day, but you don't have 2 days to do this scan because technetium has a half-life of 6 hours. Every 6 hours, the activity is cut in half. And so you get a curve, attenuation curve of signal that looks like that. So by 24 hours, there's virtually no signal left from coming from the technetium methyl diphosphonate. So that's not the only agent. There's pertechnetate, which is useful for thyroid and salivary gland tumors, thallium for parathyroid tumors, indiamoxine for white cell labeling, I-131 for thyroid. So it's a very flexible technique depending on what radioisotope you use and what you conjugate it to. So here's an example of a thyroid cancer patient who's being treated with I-131. And initially, you can see the lesion where the arrow is here. And over a course of days, you can see that the activity disappears because the tumor has been treated with the radioactive iodine. So it's not only an imaging technique, but also a therapeutic technique. Now, I'm not going to spend much time on the back projection. I've described that already. But one particular aspect of this for SPECT imaging is that it requires very close collimation. And what is collimation? Collimation is the use of these metallic dividers, essentially, that prevent stray gamma rays from getting to the detector. So it's very important that the only gamma rays that arrive at the detector have come from a certain direction. If you allow gamma rays from any direction, you're going to get garbage as an image. So it's only gamma rays arriving from a certain direction that is straight on that are useful for generating images. So this is what a collimator looks like. It's usually made out of something like tungsten, very, very dense metal. And you can see that to get through one of these holes, you've got to be, if you're a gamma ray trying to get through one of these holes, you've got to be oriented in just the right way. Otherwise, you'll just get blocked by the metal. So as you can see on this slide, German slide, you have a scintillation that occurs. This gamma ray can get through and light up the scintillating crystal, but these gamma rays are blocked. So there's some aspects to that. Number one, I told you, and you've seen it already, that the resolution of SPECT imaging is not too good. And the resolution is determined by the collimation. The tighter you collimate it, the more resolution you get, but the fewer events you can capture. And so there's a trade-off. You can't give an infinite amount of radioactivity to somebody. You can only give a reasonable amount of radioactivity, which means that you have to open up your collimators a little bit to let more gamma rays in, which means that the resolution is not too good. So the vast majority of events that occur are not actually captured by the camera, probably less than 1% of the gamma events. So what happens after the collimator is it hits a scintillating crystal, which produces a little light, and that light is detected by these photomultiplier detectors, and they in turn generate the image. So the scanner looks a lot like this, and you might notice, unlike the MRI and the CT, there are these devices. These are the gamma cameras that are on opposite side. They're very expensive, so that they're not built as a ring. You know, most of the other things we've shown are rings, but because of the expense involved with these, they're rotated around the patient manually. So that's why it looks like that. And the back end of this, I didn't describe, is this conventional CT scanner, computed tomography. And the reason to do that is to sort of recover it's a little bit of a fake, but it's a recover of the resolution by superimposing a high-resolution CT on top of the SPECT image. So here you have a node in the neck that is detected on the SPECT and then superimposed on the CT, and it looks pretty good. But the native resolution of the SPECT is very poor, on the order of 7 or 8 millimeters in dimension. So I just want a few words about safety and radioactive use. Of course, the operator is exposed every day to radioactivity, so all kinds of precautions need to be used so that the technologist is not exposed to a lot of radioactivity cumulatively. So these are protectors, so-called lead pigs that fit around the syringe so that as the tech holds the syringe, they're not exposed to a lot. And of course, the patient, we are very cognizant of the dose that's administered. And of course, we're all familiar with the mutating effects of radiation. So that brings me to the fifth of the 5 techniques that I want to describe today, and that's PET, positron emission tomography. So I mentioned one of the ways that radioactivity can occur is that a nucleus can release a positive electron, or a positron. And this is a classic matter-antimatter interaction, whereupon when this positron meets an electron, they annihilate each other and completely transform into 2 gamma rays in opposite directions, 180 degrees opposed from each other, at a characteristic energy of 511 keV. So it's really, really interesting that no matter what the energy, no matter what the source of the positron, whatever isotope you have, whatever the energy that it's released at, it always produces 511 keV photons in opposite directions. Cool. So PET has some decided advantages, some disadvantages. First of all, compared to SPECT, it's 10 to 50 times more sensitive than even SPECT, which is probably the most sensitive up to this point that we've talked about. Because of that, it can provide actual metabolic information about the tumors. It has substantially better spatial resolution than SPECT, and it can be combined with CT to give the illusion of even better resolution. But on the downside, it's a very expensive technique. It has all the regulatory issues associated with radioactivity, and typically the half-life of these agents is relatively short. So PET images, as I said, are 511 keV photons produced by a positron annihilation. They're much higher energy than what we usually use for SPECT imaging. And the photons are at 180-degree angles, which means that we can detect them at opposite sides of the detection ring. So briefly, what happens is the positron from this fluorine-18 atom is emitted, and it wanders off, depending on its energy, finds an electron, and it's love at first sight, but unfortunately short-lived because 2 gamma rays are produced during the annihilation, and those are detected simultaneously at opposite sides of the detector ring. So what do we usually do with this? Well, the most important thing is we harness this by attaching the F18 positron emitter to a form of glucose, deoxyglucose. And Warburg, Otto Warburg, in the early part of the 20th century, discovered that cancers switch from aerobic glycolysis, from the Krebs cycle, from using oxidative phosphorylation to aerobic glycolysis. So aerobic glycolysis, just like anaerobic glycolysis, takes in glucose and in a series of steps converts it to lactate via pyruvate. Much less efficient than the Krebs cycle itself, approximately 18 times less efficient in terms of the amount of glucose. So it's curious why tumors do that, but it appears that this form of metabolism provides tumors with other metabolites that are useful for its growth. For instance, fatty acid and amino acid metabolism. So for whatever reason, glucose uptake is dramatically increased in tumors. And so when you inject F18-FDG into a patient, it rapidly gets taken up into cancer cells. It's actually phosphorylated, but because of the F18 on the molecule, which the enzyme is not expecting, it's not taken further into metabolism. So what it does is accumulate as FDG6-phosphate in the cell, and it just builds up in the cell, creating enough radioactivity inside the cell to be detectable on a scan. So it's interesting. I guess this isn't going to play, but it's a little movie that just shows this 3D PET scan, and this is a little metastasis from colon cancer here that is detectable because this molecule is taken up by the tumor. So PET scans are very high technology. They involve the obtaining a PET image, also a CT image, and a fusion image, where the two are superimposed upon one another, and that's a PET CT. And this is an example of a patient with breast cancer, and you can see all the areas of increased uptake in her spine, anterior mediastinum, and you can really localize where the metastatic disease is. Oftentimes, the PET is much more sensitive than the other techniques we've talked about for detecting sites of metastatic disease. Now, there's one important aspect of this that I want to mention, although it is a technical detail, and that is that we actually have two kinds of scans going on in a PET scanner. One is called the emission scan, which is the one that I just described. So it's the clinical image obtained by imaging the distribution of the tracer emitted inside the patient. But another scan that has to be performed is the so-called transmission scan, which is a map of the patient indicating what the likely path of the gamma ray or photon is through the patient and how much that is likely to attenuate the X-ray, or not the X-ray, but the gamma ray. So the reason why that's important is if you don't correct for it, you get kind of artifacts like this where there appears to be activity in the lung where there really isn't. But after you correct for the attenuation of the lung, you can get a much more reasonable image of what's going on. So PET imaging has the advantages of being very high energy, photon imaging, high sensitivity with good specificity, the ability to correct for attenuation, no need for collimation because of this, the 180-degree difference between the two gamma rays. Resolution is still limited compared to other techniques like CT or MRI, but it's still very, very good. So I want to summarize what we've talked about. I presented the various techniques in this order: CT, MRI, ultrasound, SPECT, and PET. If we think about the resolution, what's at the top of the pyramid for resolution? It looks almost like what I presented. But CT has the best resolution, MRI better than ultrasound, which is better than PET, which is better than SPECT. So that gives you some idea about what you can resolve in terms of the smallest lesion. For instance, for a SPECT, we're really talking about a 1 centimeter lesion is the minimum you can detect. Whereas with CT, you can probably detect sub-millimeter sized lesions. What about sensitivity? Well, here the order is almost reversed. PET is by far the most sensitive technique, followed by SPECT, ultrasound with microbubbles, MRI, and then CT. So CT is the least sensitive, which is why you need to put 40 grams of iodine in before you can even detect it. And then cost, from low to high. Ultrasound, it's the low budget item. In fact, in the third world, ultrasound is the technique that's used. But in the developed countries, CT, SPECT, MRI, and PET in terms of cost. So how do you use these techniques? Overall, I'd say, as I began, that CT is the workhorse for oncology. Most patients get a CT scan. For special cancers like brain, liver, prostate, MRI is the first choice. And certainly for people in whom radiation, cumulative radiation is an issue, we like to switch towards MRI to avoid cumulative burden of radiation. For problem solving, for instance, whether a lesion that's seen on a CT is a cyst or it's solid, ultrasound is a great technique. It takes 30 seconds, a minute or so, and you can really get the answer to that particular problem. But as a means of screening or evaluating patients with cancer, it's really not used, at least not here. For bone metastases, the bone scan using SPECT technique is the method of choice. And for detecting metabolic activity, particularly for detecting small amounts of highly metabolically active cancers, PET scan is the first choice. And then for monitoring patients, we use a combination of these, either CT, but also increasingly PET is used. So that's sort of my summary of what goes on in a radiology department. We have a website for our group that's on the screen. And if you have any questions beyond here, feel free to contact me. Thank you. So are you referring to like proton therapy? Yes, okay. Yeah, so I'm not an expert in radiation oncology, so I may be speaking through my hat a little bit, but as opposed to what's the normal kind of radiation delivered for therapy is X-ray based photons. And they, of course, go through everything, as we've described, whereas protons, as a heavier subatomic particle, are blocked, so they can be aimed more specifically, in theory anyway, so that if you have a target organ, by applying the protons in various directions, you can confine the radiation damage to the area that you prescribe. That's at least in theory. In practice, I'm not sure how things are going. Deb Citrin would be the person to ask. Thank you. Thanks. I'm good for another year. Appreciate it.
And our next speaker is Anton Simonov. He works at the National Center for Advancing Translational Sciences. And he's going to be talking about the use of advanced technologies in small molecule drug discovery. Anton.
Thank you. This be good? All right. Thank you. thank you all for hanging out this late. I'm happy to be here to tell you a little bit about their work at NCATS using advanced technologies to discover small molecule modulators of proteins and pathways. Just brief introduction to what I'm going to be talking about. I divided the presentation into 3 segments. First, I'll tell you briefly about the overall concept of using high-throughput screening to discover small molecules that affect proteins or pathways in vitro or cellular context. I'm going to give you a couple of examples of assay systems and screens that we've run against some novel, challenging targets as related to oncology and other areas of biology. There's been some surprising developments we've screened, and at the end I'm going to spend a couple of minutes telling you about sort of another way to arrive at a drug, the strategy of finding new uses for existing clinical agents, also known as drug repurposing. Just at the beginning, a couple of terms that I'd like to sort of review with you, even though these definitions are not sort of final, fully accepted by any means, but they kind of illustrate their view on things by those who practice screening and small molecule discovery. Small molecules are generally less than 1,000 Daltons in molecular weight, and they can be natural product derived, fractionated from plants, fungi, and so on. They can also be synthetically derived, and as you perhaps know, most therapeutics are small molecule type, and most of those are synthetically derived through organic synthesis, also known as medicinal chemistry. So I'm not going to be talking about discovery of, say, therapeutic proteins or monoclonal antibodies. Those are really subject to sort of different discovery strategies and different sequence of techniques applied to arrive at the final moiety. So what is an assay? It's an interesting term that people use very loosely out there. For screening, an assay has to be a test of that provides a readout of the small molecule's binding affinity or capability towards isolated protein target, or its functional activity or modulation of the functional activity of a protein, subcellular structure, or entire organism. And an assay is not just any protocol out there. For example, a complicated immunofluorescent staining protocol is unlikely to be an assay because the steps are many, and it probably won't be performed in low volume on a high scale, and it probably won't be reproducible because you may have to use various arbitrary techniques of deciding what's the outcome. So an assay in the context of high-throughput screening has to produce enough signal to background value. Additional assay statistics are required. It has to be reproducible and, again, scalable, because, as you see with the next term, high-throughput screening is the repeat execution of an assay in miniaturized format to determine the activity of many, many small molecules contained within these libraries that typically get tested in a high-throughput screening campaign. And that leads us to the concept of a library, and it's simply a collection of anywhere between 100 to a couple million small molecules, typically present as 10 millimolar stock solutions in dimethyl sulfoxide, and those get tested either in a massively parallel way or somehow sequentially. You'll see in a moment how we do it. Obviously, in order to get results on so many samples or molecules, your assay has to be really reproducible, scalable, and ultimately relatively cheap and efficient. So that means certain traditional protocols, again, like immunofluorescence staining, preparation of slides, Western blots, don't really qualify as assays in this sense. So with this brief intro, I'd like to also kind of transition this to tell you that today I'm going to be talking mostly about assays, assay formats, performing high-throughput screens, optimizing small molecules, and testing their effects. But the whole concept or process of starting from some biological information to ultimately arriving at a drug or clinical agent that would be approved for therapeutic use is a very lengthy process. Costs anywhere between tens of millions to hundreds of millions of dollars, and the failure rate in the process is well over 90%, depending on how you define the starting point and the end point. So what we do at NCATS is we're engaged in all these additional activities that I'm not going to be talking about. For example, we house the Trans-NIH RNAi core facility that performs high-throughput siRNA screens to deal with this whole concept of target discovery, target validation, discovering new genes that affect certain process. So basically really doing the early part of discovery of drug targets all the way to optimizing molecules, conducting preclinical development, and going into clinical trials. So these are subject to various distinct programs within NCATS. For example, preclinical development is housed within the Therapeutics for Rare and Neglected Diseases program at NCATS. We're also conducting a lot of these repurposing screens, experiments, and on the extramural side, we're funding actual clinical trials that deal with drug repurposing. Given the high failure rate and given the fact that what you're seeing is really what's happening in large pharmaceutical organizations, in biotechs, you may ask yourself, okay, why is NIH, NCATS, academia doing any of this? Obviously, this is the sweet spot here. This is what NIH is good at, discovering new targets, new biologies. But the high failure rate and the fact that there are a lot of diseases, specifically rare genetic disorders, tropical infections, that are really of very low commercial value to for-profit organizations, meaning there are many targets and biologies that are not addressed by the for-profit organizations. It is the space where we operate in to de-risk novel therapeutic strategies, to look at underserved diseases, such as, again, rare genetic diseases, and ultimately to produce data sets, tools, and occasionally drugs to help improve the process of obtaining final therapeutic agents. And I'll continue in a moment by telling you how we actually improved some of these processes. So long story short, we work on things that are really not mainstream pharma-type targets, the blockbuster drugs. They're well served within the commercial space. So you'll see sort of strange protein categories, things that are not mainstream yet and have their own challenges. So in terms of screening assays, one can look at various levels of reductionism. One can look at isolated proteins, such as measuring enzymatic readouts, looking at disruption of protein-protein interactions, protein DNA interactions, and so on. And I will be giving examples to this effect. One can look at pathways through reporter gene assays and various other readouts. You're no doubt familiar with some of these reporters. And one can also look at the higher level pictures, such as phenotype-based measurements of cell shape, translocation, organelle change of morphology, as well as cell death, for example, the killing assays that are performed on live bacteria or other microorganisms. So we're equipped to do all of this. And in terms of technology, what has been happening over the past decade or so is really a transition from the traditional 96-well plate format all the way to this highly miniaturized array of 1,536 well plates, where you can see one such plate is equivalent to 16 traditional 96 well plates. So this gives you a lot of real estate to have enough positive, negative controls, and to test a lot of samples, 1408, if you reserve 4 columns for controls, relative to the a lot less samples in the 96 well plate. Volume is decreased per test, so you achieve savings in terms of reagent costs, and time to run a screen of certain size libraries dramatically decreased. That also translates into less of a need to have large batches of reagents or to produce multiple batches of the same characteristics, because with the same amount of reagent, say 1 protein prep, you can run the entire screen if you're able to reduce the assay into the small enough volume, which is typically between 2 and 8 microliters per well, as opposed to sometimes 100 to 300 microliters per well in the 96 well plate. Of course, not every assay is miniaturizable to 1536 type plate. There is increased surface to volume ratio and associated issues. So when we work on these assays, this is the first sort of aspect that we look at. Will the assay perform the same way in this format as it did in say, 96 or 384 well plate? In terms of running a screen, we're set up pretty much at the level of a large-size pharmaceutical company with fully integrated robotic screening system where compound libraries reside on the system, so we can screen any compound, any plate in sort of random access fashion. We can deliver reagents through various dispensers to perform various addition and washing steps. We can centrifuge plates. We can incubate plates for, say, mammalian cell-based assays. We can run those at 37 degrees, 5% CO2 for up to 3 days without appreciable evaporation of samples. And we can read signal through various plate readers that are integrated in the system. One thing that we began to do differently, and this is really a considerable improvement in the process of high-throughput screening, is to actually generate dose response or titration data on every sample tested. And you may think, well, this is intuitively obvious, right? I mean, it's been stated, 500 years ago by the father of pharmacology, that it's all about the dose. If you supply a dose that's too low, nothing will happen. Maybe some intermediate dose of the agent will cure, and very high dose will kill. So turns out in traditional high-throughput screening, throughout the years, people have been testing the compounds at a certain single concentration, sometimes including a replicate, maybe running the screen in duplicate or triplicate, but not really exploring the whole concentration range because it was viewed as too expensive and technologically impossible. But when you miniaturize to 1536 well plates and actually shrink this volume, you can do it, and we've developed processes to array these libraries as plate-to-plate dilution series. So imagine in a normal sort of microtiter plate experiment, you would array the dilution series within the plate, maybe left to right with a multi-channel pipetter or down a column. Here we actually do it plate to plate. So these different intensity color dots indicate the small molecules dissolved in DMSO. The bottom plate here is the top concentration stock solution. We serially dilute across plates. And then when we run the screen of these sort of stacks of plates, we can derive the dose response curves. If there is a flat response, obviously that molecule is inactive. If there is sigmoidal dose response, that is fitted to the Hill equation. We can derive Hill slope, AC50, EC50, whatever you want to call it. We can define asymptotes, efficacy, and so on. The fact that we dilute plate to plate and not within the plate gives us flexibility. If the screening assay is extremely expensive, we can skip some of these plates. They're all arrayed as sort of random access collection within the robotic system. In a terminal situation, we can just screen one concentration, just picking that particular plate, whereas if the dilution series was within the plate, we would be stuck with having to test the entire dilution series every time we run a screen. We developed informatics platform to classify the different types of responses. We can look at shallow curves. Obviously, those have relevance in say, receptor type assays and other biologies. One does see shallow responses. They have biological meaning. We can capture all those and basically create these curve classification categories automatically, and then provide data summary. And notice the following aspect of this whole process. If a compound is inactive, but due to noise in the assay, you have a single point outlier, like it's shown here. If you did not run the compound as multiple point dose response, you would have classified this particular output as a positive, as a hit. You would have then reprocured that sample, spent the time and effort to retest it, only to find out that it's a spurious noise, or maybe a detector issue, or maybe a dispenser added little extra reagent. And then obviously that constitutes waste. So yes, we front load the library with having to run more plates at the beginning, but we recapture some of this costs by having to retest less compounds, because embedded in this system is the detection of a lot of these instrument-dependent false positives. So all of this is done automatically at the average rate of about 1 dose response per second when you average out the multiple samples tested. And the average size of our compound library is right now about 500,000 compounds. So this is another way to sort of look at the system through various photos. Depending on the assay protocol, the complexity of the assay, we can screen up to 2.5 million wells or samples per week. So when you look back at the 500,000 compounds that we have, and imagine just for a moment that they're all tested at 5 concentrations, basically the entire library can be tested within a week, providing dose response curves for every molecule. And pretty much all of this information is deposited in the public domain in PubChem, and to date we've deposited almost 10 million dose response curves, more than any pharmaceutical organization to date. So we also have, so I forgot to mention, the system that I showed you just now is capable of running biosafety level 1 and 2 type assays and protocols. We also can run biosafety level 3 type screens. So this is a robotic system that is almost next door in building 33 with the infectious disease group on the main campus here. Obviously, protocols are very difficult to set up in these settings. You know, you have to go in fully suited up and all that. But in whole organism assays of, say, tuberculosis type species and anthrax and so on, you definitely need this type system. And this is not meant to be read in detail, but it's just an illustration of the fact that we can conduct fairly complicated protocols. They require sealing plates, peeling seals, performing multiple readouts, all within the system across multiple plates. And we've run a 13,000 compound library in dose response against MTB in various formats, so we can address some of these infectious disease categories. I'm going to switch gears and start giving you examples of various assays that we've had to develop for running these high throughput screens. One category of protein targets that we had to address with various collaborators is proteins involved in DNA repair. You don't see inhibitors of DNA repair in sort of everyday literature around novel drugs. Mostly people talk about PARP1 inhibitors, not much else, but there's really growing interest in discovering specific inhibitors for various DNA repair enzymes, proteins, not only to understand the basic biology, but to hopefully use them as combination agents in cancer therapies. We faced multiple challenges when trying to set up screens for those proteins because they have very unique substrate requirements. These all work on various unique DNA structures. Some of those structures are, as you will see in a moment, very hard to recapitulate in a test tube. And it's really hard to set up cell-based assays to give you a readout on DNA repair in most cases. And a lot of the existing assays, they would typically be applied after screening, are based on radioactive type platforms and as such wouldn't be applicable to testing large number of samples. So one example is the FLAP endonuclease FAN1. So it's the main human endonuclease that deals with this aberrant structures where there is a flap created through the work of DNA polymerases during DNA repair in growing cancer cells. And so the question is how to convert a radioactive assay into something that is amenable to high-throughput screening. So to do this, we generated this substrate where the flap structure is unperturbed here, and we placed fluorescent donor and quencher at this distal part of the molecule such that FAN1 can still work on this part of the molecule, which is pretty much like the natural substrate, and the donor and quencher dyes or appendages wouldn't be interfering with the enzymatic activity. This way you can test the reaction in the most native state. So when FAN1 clips here, removing this flap to set the stage to further repair this structure, the fluorophore piece, which is liberated, it's held normally through only a couple of base pairs in an intramolecular donor quencher annealing fashion, almost like a molecular beacon. When you have dissociation here, this piece spontaneously dissociates from the rest, and you have basically an unquenching effect, and the fluorescence will go up, and these are the actual sequences we designed to test this. We also designed the second assay where we had a single flap structure, also processed by FAN1. We installed reporters at the termini here, upstream and within the flap. Fluorescein and biotin, they can be embedded in the structure through chemical synthesis by the oligo company very easily. They serve as attachment points through streptavidin and anti-fluorescein antibody for these donor and acceptor colloidal particles, which serve as a system to create chemiluminescent signal. We illuminate using redshifted light source, 680 nanometer centered. In this case, the donor absorbs this light, generates free singlet oxygen species which diffuse in the aqueous system, but as they encounter water molecules, they get quenched, and so they can only travel limited distance in solution. And if by the time, before they get quenched by water, if they encounter the acceptor colloidal particle, they can react with chemicals embedded in that particle, trigger chemiluminescent reaction, and the acceptor bead or particle will emit with blue shifted light. So notice this is a process that's opposite of fluorescence. In fluorescence, you normally excite with higher energy blue shifted light, and you get redshifted emission. Here it's the other way around. Why is this important? A couple of reasons. First, unlike energy transfer, this system doesn't depend on Förster's distance as much. So it's easier to optimize an assay without having to think too much about the distance between these attachment points. It basically works most of the time, including on large proteins. Second is, because this is in direction opposite of fluorescence, all the autofluorescent molecules in the system won't interfere with the signal generation. So these assays tend to have very low background and fairly strong signal. And again, placement of these moieties at the end of the substrate allows the FEN1 enzyme to attach itself and do its job without, again, interference from these extraneous pieces. We tested these substrates also on radioactive version of these oligos to show that FEN1 indeed cleaved them at the expected positions. And we're now setting up a screen for FEN1 inhibitors using this format. Another system in DNA repair is this entire gene family of specialized DNA polymerases, also called translesion polymerases. Here we actually work with a couple of NIH intramural investigators, Sam Wilson at NIHS down in North Carolina, Roger Woodgate from NICHD, and also with extramural investigator Stephen Lloyd to test Pol Beta, Eta, Iota, Kappa to find specific inhibitors for those. So the challenge here is these are not your regular polymerases involved in DNA replication. They're very slow, they have low processivity, low catalytic efficiency. They're only involved in processing lesions such as thymine dimers, 8-hydroxyguanines, things that are formed either through spontaneous chemical modifications or upon treatment with, say, cisplatin and other anti-cancer agents. So these are error-prone polymerases. They basically insert something, a base, across the lesion, allowing the strand synthesis to continue. So they associate with the strand for only the incorporation of one or two bases, then they dissociate, allowing the regular proofreading polymerase to take over and continue the DNA synthesis. So setting up an assay where you simply look at the amount of DNA produced by the polymerases is impossible because they don't make a whole lot of DNA. So to set up an assay in this case, we set up the following system. We had a primer shown here in blue, a template strand labeled at the end with a quencher moiety shown here. Downstream of the primer, we had a reporter oligo piece labeled with a fluorophore. Upon insertion of one or more bases by the polymerase in the presence of the NTPs, the strand is extended just by one or two bases. It leads to displacement of this reporter because by design, this is held by only a couple of base pairs. So its melting temperature is adjusted to be only slightly above room temperature. So as a substrate, this is stable on freeze-thaw cycles with time in buffer. But as this gets peeled off by just one base pair, it spontaneously dissociates, and then you have a release of fluorescence. Of course, we had to work for quite a bit to design these sequences, but this is a couple of graphs showing the assay validation. We indeed depend on presence of the NTPs, on the enzyme to produce signal, that these substrates undergo multiple turnovers, and if you label them with fluorophore quencher as intended, but also with P32, you get the anticipated extension by the various polymerases. So the polymerases recognize these new substrates, and they actually do extend the primer. and this is the statistical performance of these assays in initial pilot screens. Another DNA repair category, again, small gene family, is the RECQ helicases. There are 5 or 6, depending on how you count them, RECQ helicases. One of them is the Bloom syndrome helicase. So these are involved in unwinding DNA and participate in various forms of DNA repair. They utilize ATP and act as molecular motors to unwind and separate the strands. So in this case, we again designed fluorescence donor quencher assay, placing the donor and quencher, again, distal relative to this fork duplex substrate. So it's basically a stretch of complementary bases followed by a stretch of non-complementary bases. So the helicase will bind to this end. When it's supplied with ATP, it will begin to unwind the strands, and at some point, the affinity here becomes too low. Melting temperature is below room temperature, strands separate, and you get unquenching of fluorescence. We use this assay to screen about 250,000 compound library and found this small molecule as a hit from the screen. Our medicinal chemists performed multiple rounds of optimizations to derive this final Bloom inhibitor, which was also tested in a radioactive assay to show the same type of inhibition. Based on limited enzymology, we believe it's competitive with respect to the DNA, branch DNA substrate, and not with ATP, which is the desired mode of inhibition, because if you have an ATP competitive helicase inhibitor, you're probably not going to get very far with such a molecule because intracellular ATP concentration is fairly high, so you wouldn't have a very efficacious inhibition in that case. Inhibition of Bloom helicase has been shown to lead to increase in sister chromatid exchanges, and this is indeed what we see when we apply this inhibitor. We only see it in cells that have the Bloom helicase and not in cells that lack the helicase, which shows specific on-target effect, and this is the result of cell viability testing using the inhibitor at 2 different concentrations. We see dose-dependent cell killing only with the cells that do have Bloom helicase and not in the cells that don't. So these are patient-derived cells from Bloom syndrome patient, and these have Bloom knock-in. Another target category where we did extensive work in is basically a gene family or several families that deal with post-translational modifications, but they're not kinases or HDACs. This is really, again, following along the lines of contrast between what we do, what's happening really in academia versus what's been happening in pharmaceutical organizations, where really kinases have been screened and developed for the past several decades, and really pharma is very well suited to develop even more kinase inhibitors. But what about, and increasingly HDACs, what about post-translational modifications that are emerging? And what I'm going to be talking about mostly is the area of epigenetics. Granted, it's no longer an emerging area, but it was until literally a year or 2 ago. And within our group at NCATS, we developed first-in-kind assays for the 3 main categories of modulators of this histone code. And again, by epigenetic proteins, I mean proteins involved in histone modifications, not in DNA methylation or demethylation. Just small distinction here. So these are roughly divided in these 3 categories: the writers, readers, and erasers of the histone code. Writers are enzymes that install the post-translational modifications, the histone methyltransferases, acetyl transferases. Here, the organizations we collaborated with to develop the assays. Readers are proteins that do not catalyze any reaction. Rather, they recognize, bind the epigenetic marks, that is, lysines, arginines that are differentially methylated or acetylated, and they further recruit transcription factors or other proteins, and these are bromodomains, chromodomains, and other domain families. Lastly, the erasers of the histone code remove the epigenetic marks. Most prominent, these are histone demethylases. And of course, HDACs, but that's a category that is well served by pharma. Briefly on the assay formats for these, for the writers, we worked mostly on lysine methyltransferases, specifically G9A. This is an existing assay, coupled enzymatic assay for histone methyltransferase activity. The main reaction shown here is coupled with several additional enzymes to ultimately produce fluorescent signal. When we tried to miniaturize this reaction to 1536 well plate, it literally fell apart. So many components were highly sensitive that we could never scale this up to run a large screen because of reagent incompatibility and instability. So we had to design a de novo assay to screen for methyltransferases, and we used, again, this chemiluminescent AlphaScreen platform that I showed earlier. We start with biotinylated peptide that represents a segment of the histone protein with appropriate level of methylation or lack of methylation of side chain lysine. In this case, this is a cartoon of H3K9, for example. Short peptide upon the action of histone methyltransferase. In this case, one methyl group is added to produce monomethylated histone peptide. This is recognized by specific antibody. There are a lot of such antibodies available through various vendors with different specificities. In this case, it's monomethyl H3K9 specific antibody. In turn, that antibody is recognized by secondary antibody on the colloidal particle. Streptavidin is used to attach the other particle to the biotin. And only when there is installation of methyl group, you get the two particles to be co-bound to the same molecule here, and you get a high chemiluminescence signal. We tested this assay in 1536 well plate with G9A and the related methyltransferase with excellent signal to background and plate statistics. Now, not every assay is devoid of interferences. In fact, most screens produce a lot of garbage. What do we mean by that? A lot of false positives are not instrument-specific or spurious in nature. They come from non-specific effect of small molecules on the test system itself. For example, small molecules can be fluorescent, or they can be colored and therefore quench light. They can be redox active and interfere with the redox chemistry of the assay. They can be luciferase inhibitors and interfere with luciferase reporter gene assays. All of these are inherent activities of the small molecules. So having good instrumentation won't solve the problem of the inherent activity of the small molecule. Change of assay format or knowing how to screen for the spurious false positive activity will help one determine what is a real hit and what is a false positive. So in this case, we had to develop an entirely different counter screen assay for compounds that interfere with this signal. These can be, again, redox active molecules. They can be colored molecules that interfere with this emitted chemiluminescent signal. They can even be biotin mimetics that interfere with streptavidin binding to biotin. So we shorted the assay by using an antibody labeled with biotin, bringing the two colloidal particles together outside the context of the methyltransferase reaction. So if a false positive is tested in this assay, it should give an effect or a signal, because it would act here on this process and not on the catalytic reaction that installs the methyl group. So we tested this with a known inhibitor of methyltransferases, the BIXL1294 compound. It produced largely flat effect in the counter screen. It was nice inhibitory in the main assay, whereas a false positive, this reactive blue 2 molecule, produced uniform signal not only in the enzymatic assays, but also in the counter screen, therefore flagging it as false positive. So this assay was also used to actually develop improved analogs of this BIX molecule in structure-activity relationship study, and it was able to report on the change of potency of these molecules in sort of blind test of this format against an existing radioactive assay. So we consider this assay fully validated and will be running large screens. Moving on to the middle category, the readers. As I mentioned, these are proteins that just bind to differentially methylated or acetylated histone variants and don't perform any catalytic reaction. They're very state and site specific, meaning they can tell apart monomethylated, dimethylated, trimethylated histones, H3 versus H4, K9 versus K37, and so on. But invariably, these interactions have very weak affinity. Most of the time, micromolar up to 10 micromolar Kd. So a lot of energy transfer, fluorescence polarization, and other assay formats don't work very well in weak interactions like this because you simply don't have enough fraction bound. You can't utilize the leverage of, say, catalytic turnover. So again, we used, in this case, the chemiluminescent strategy by producing the reader domains with affinity tag, which is something that people do as part of their routine procedure to express these proteins, whether it's hexahistidine tail or GST tag. It provides a handle, again, to bind one of the particles, in this case, the acceptor particle, coated with anti-tag moiety, nickel chelate or anti-GST antibody or GST itself or glutathione itself. Again, the biotin-related peptide here serves as a representation for the histone protein carrying the particular post-translational modification. If you have a disruptor of this interaction, this will result in loss of signal, and you will clock that compound as a positive or hit in your screen. To date, we've run one bromodomain screen against the entire collection, well over 1,000 1536 well plates with excellent Z-prime statistics for the screen, and we're in the process of validating some of these primary screening hits that we got from the screen. The last category is the erasers, enzymes that remove post-translational modifications, and I'm going to talk about the Jumonji domain histone demethylases. So there are two main categories of histone demethylases: the LSD family, lysine-specific demethylases. Those are different subfamily distinct from the JMJs shown here. LSDs and analogs are like monoamine oxidases. They use flavin cofactor to remove the methyl group. JMJs catalyze this complex reaction that uses iron, utilizes molecular oxygen, and several additional cofactors. This is, again, not meant to be read in detail, but only a couple of years ago was the first structure of Jumanji demethylase determined, and that obviously served as a basis for understanding the reaction and design of some targeted inhibitors. But this shows the reaction in sort of more reductionist manner. These enzymes use oxoglutarate as a cofactor. Again, molecular oxygen, they need ascorbate to keep iron in reduced state. And ultimately, they remove one methyl group at a time, producing succinate, carbon dioxide, and formaldehyde as one of the products. To generate the screening assay, we coupled the formaldehyde produced at this step with a formaldehyde dehydrogenase enzyme, and we monitored in kinetic mode the generation of NADH product, which is fluorescent itself in high throughput mode. Lots of optimization work to get this assay up and running in this highly miniaturized format of total of 4 microliter volume. We had to do a lot of optimization to figure out what can be combined as a reagent source. So keep in the back of your mind this whole notion of no, high throughput screen is not thawing reagents, running the assay within, say, 20, 30 minutes on, say, 20, 30 samples, and throwing everything away and analyzing your data manually. It's setting up large bottles of several liters of reagent and running this 24/7 for several days. So reagents have to be formulated in a way such that they survive this long stay at the screening system on ice, maybe at 4 degrees C, but you can't really be making them fresh every, say, 20 minutes or 2 hours. So determining what can be combined into a single bottle of combined reagent took a while, because, again, if you do this manually, you can presumably formulate everything separate, mix it just in time to run the reaction, and call it a day. But for high throughput screening, you have to simplify the protocol down to as few addition steps and reagent bottles as possible. So this took well over 2 months to figure out, just after figuring out the general assay format. Something else to mention here, which will be of importance later, the LSD family of histone demethylases cannot remove methyl groups from trimethylated histones. Only the JMJ family can do that. So for processes where you need to remove repressive marks on histones starting from, say, H3K9 trimethyl, the JMJDs are the first enzymes that hit that histone tail and not the LSDs. So there's an area of sort of non-redundancy there. Once you remove the first methyl group, both gene families can work on the substrate. So we ran a screen using this coupled assay. We followed the screen with a lot of cheminformatics analysis, looking at fluorescence interference by the small molecule hits, looking at the curve quality, performing counter screen for inhibitors of this coupling enzyme, which may show up as hits in the screen, confirming the inhibitory activity, running mass spec-based assay. And here is one of the inhibitors that we arrived at. It wasn't very potent enzymatically, couple hundred nanomolar IC50, and it was not specific against an individual Jumanji demethylase, but it was selective for JMJ demethylases against related enzymes that utilize molecular oxygen and oxoglutarate as substrates, the HIF-prolyl hydroxylases, which was good. It wasn't a pan-active molecule. Crystal structure allowed us to further rationalize the binding and make improved analogs, which you will see in the next slide. And this really laborious immunofluorescent type assay showed that the compound had an effect inside the cell. So our medicinal chemistry team synthesized well over 100 analogs of this initial molecule to try to improve the ADME properties. So a lot of times making analogs of the initial screening hit is required to improve its main activity against the target screen. But in order to progress a molecule beyond in vitro, in test tube analysis, if you will, in this reductionist setting to, say, an animal-based experiment, xenograft, or to move it to a patient trial, you need to improve other properties such as stability in plasma, stability against microsomes, against various enzymes in the body that will degrade the molecule and contribute to the molecule's clearance. So all of these are referred to as ADME properties, and of course there's even more optimization to improve pharmacokinetics, pharmacodynamics, and all that. So analogs are made not just to improve the way the molecule binds to the main target, but to improve other properties as well. So this molecule has been sent to about a dozen labs across the US and overseas for tests in various cancer models, because there are various studies of Jumanji demethylases as contributing to cancer metastases and development. But to our surprise, we also set up a collaboration to test this Jumanji inhibitor against an infectious disease, working with someone on main campus, Thomas Christie, at the Infectious Disease Institute, to test something that their group had discovered just recently, which is the whole notion of targeting the host-parasite interactions with epigenetic inhibitors to modulate virus infections. So they discovered the members of the herpes virus family, herpes simplex virus, human cytomegalovirus. When they infect human cells, their viral DNA is compacted into chromatin-like structures that bear repressive marks, meaning their genes are silenced right after infection, and they use the human host's histone demethylases to reverse this silent state, to activate gene transcription, and to begin to transcribe their genes, to multiply, to basically continue the infection, and to also initiate the reawakening or reactivation after latency, because as you know, these are viruses that can go into latent state, and occasionally every couple of months or years you may have a flare up and you get cold sores and you have to get the ointment going and all that. So the ointment we'll revisit in a couple of slides treats the replication step of the virus life cycle, whereas this approach carries the potential to treat an earlier step of the viral life cycle, which is the initial transcription of viral genes. So we tested our compound shown in the earlier slide in various models of herpes simplex virus infection. So this is showing the effect on transcription. The compound, as expected, affects mostly the early, intermediate, early genes in the virus life cycle pretty dramatically in dose-dependent manner, whereas it doesn't affect the late-stage genes shown here. This is herpes simplex virus, and we have similar results with cytomegalovirus. In viral killing assays, it has a very strong effect in culture. Also in these plaque assay leads to almost complete obliteration of the virus. In cell-based testing of viral replication, shown here on the left, the viral replication protein marker UL29 is shown here in green. To briefly orient you, this is mock treatment with vehicle. This is actual infection with herpes simplex virus. DMSO treatment, you see lots of green spots showing basically that the virus infected the cells and replication is ongoing. Treatment with the standard of care, acyclovir, which is in a lot of these ointments for cold sores, leads to a reduction in replication. Treatment with our Jumonji inhibitor leads to almost complete reduction in replication. So basically, we can stop this infection with cells that are first infected with the virus and then treated. So we prevent the further amplification of the virus. Now, here we have an ex vivo experiment where mice were infected with herpes simplex virus, allowed to grow and be fed for a couple of weeks. The infection reached latent state. Mouse ganglia were taken out of the animals, placed in tissue culture medium, which leads to reactivation of the viral infection. At this point, we treat with compound or DMSO, and we look in this case for red staining, looking at individual neurons or clusters, and these are pairs of representative sections. It's all quantitated here based on clusters and single cells. As you can see, treatment with the demethylase inhibitor leads to almost complete obliteration of reactivated virus. Acyclovir also leads to reduction as expected, but nowhere near the levels achieved with the demethylase inhibitor, even though it's used at twice the concentration. So we don't know right now whether this inhibitor will become a drug for herpes virus. Obviously, the journey is very long. We haven't run actual in vivo animal studies. These are ex vivo experiments, and we're obviously very far from clinical trials, but at least we're able to use the small molecule to provide initial proof of concept that inhibiting the host histone demethylases can be used to modulate the herpes virus and related virus infections. So last topic I'd like to cover in just a couple of minutes is this whole concept of, okay, if it takes hundreds of thousands of compounds, lots of screening, medicinal chemistry, and many years and dollars to get to a final drug, isn't there a way to create a shortcut taking existing drugs that are already approved, currently marketed, or agents that have been through some clinical testing, run them through some screen against new indication, and maybe in a year or two after some reformulation work and new clinical trial, arrive at a new drug. People have been trying this in various shapes and forms, sometimes arriving at a rational hypothesis and literally taking one or two known drugs and starting a new clinical trial. So really kind of shortening the cycle tremendously, or they subject drugs to high throughput screens to find new hits and new leads for this abbreviated development. This assumes, though, that you have all the drugs available to you. And the first question that we tried to answer a couple of years ago was, do we even know how many drugs are out there? And what is a drug, especially in the context of small molecule drug that is suitable for placement in the microtiter plate to run a screen? So obviously not the monoclonal antibodies or inhaled anesthetics. Those can't really be put in the traditional microtiter plate format to be run in traditional screens. It took our informatics team several years to go through databases worldwide and construct a new browser and database along with publication detailing the process of how many agents are out there that have been approved for using man in one shape or form. Some of them are obviously currently marketed drugs. Others have just gone through clinical trials shown to be safe in humans, but have not been approved for various reasons, business reasons or efficacy and so on, but have been through most of the preclinical development. So we made the browser and database available to the public, and we also began our work on collecting the physical samples. So here is roughly the breakdown. Overall, there's little over 7,000 agents that are approved for using humans one way or another. And again, you may think, well, isn't the FDA the ultimate source of all this information? Answer is no. FDA does not have a database of all the agents. You can easily search what drugs are currently marketed, but you can't find all the agents that have been approved worldwide. So again, this took a lot of effort. Collecting the physical samples is an enormous undertaking. Obtaining the first 1,100 or so drugs is very easy. A lot of vendors sell them as collections, and you probably know about the NIH clinical collection, the Johns Hopkins drugs collection. They're all around 1,100 to 1,200 members each. They're almost the same. Obtaining the remaining couple thousand agents is really tough. So it's still work in progress. Right now we have little less than 4,000 agents. And just brief example of how we use this collection. This is an example of chronic lymphocytic leukemia. We work with main campus investigator to test cells obtained from 6 CLL patients from the clinical center, compared them with cells from 5 normal non-cancer patient donors. We use cell viability as a readout, looking at ATP, and the desired profile for the agent in choice was differential cell killing. It's very easy to kill mammalian cells, but can you find an agent that kills CLL cells while sparing regular type? Long story short, we found an old drug used to treat asthma, Oranafin, shown here, that showed the best profile out of multiple other cell-killing agents. And to actually begin clinical testing, we partnered with Kansas University and the Leukemia and Lymphoma Society to enroll patients and actually initiate clinical trial. Last slide, I realize I'm going over time, sorry about that, is really a source of information for you all. I mentioned assays, I showed you various assay formats. I mentioned high throughput screening. How do you learn more? We actually have an ebook that we've been working on for the past 8 or 9 years. It started as the in-house Eli Lilly assay development manual. Took us a while to convince the Lilly lawyers to release that in-house manual, and through the effort of many people listed here and not listed here, we've evolved the various chapters. Initially it was just a website. Now it's an entire ebook on the NLM website. I encourage you to look at the various chapters and learn more about setting up assays, analyzing data from screening. You can go in depth, you can skim through chapters. Of course, our work is only made possible through collaborations. At NCATS, we don't own any of the biologies that I showed today. All projects come to us through the efforts of people like you from the individual labs that work on the particular biologies. We're basically the techno hub for discovering small molecules. And I'd be happy to answer any questions if you may have. Thank you. Thank you.